medial collateral ligament. If you have one very interesting thing, the function of the meniscofemoral ligament, posteriorly restrained to posterior draw, that I thought is very important. And even in the deep deep medial collateral ligament, this is the secondary restraint to valgus at 60 to 90 degree. So these ligaments of the meniscus has its own important role of the knee stability. So that's another nice slide. If you see the important things, what I learned from it, if you see the medial meniscal length is 45.7 centimeter. As per the lateral meniscal length is 35. Medial meniscal is lengthier than the lateral meniscal. And the circumference of the medial is 99 millimeter, and that of the lateral meniscus is 91. So medial meniscus is longer, larger, wider, the more width as compared to the lateral meniscus. So about the composition, mostly it is comprised of water, 72%, and 22% has collagens, 0.8% has glycosaminoglycan, DNase. When it was dried, mostly goes with the collagen, then non-collagenous protein, and then 1% that has amine. Histological, the fiber orientation, that had its own very important value to the structure of the meniscus. The meniscus, it's a wedge-shaped like structure. If you see the superficial, it is being randomly arranged and it is mimic like a cartilage. And that's where it lowered the friction between the meniscus and tibia and femur. And then it's go in the deeper area that 1/3 of the fibers are radial pattern fibers and 2/3 are the circumferential fibers. And that's been in the circumferential pattern. This orientation, this have very important to restrain the load on the knee joint. So if you see on the cellular structure, what is the meniscus? It's a stratified fibrocartilaginous tissue. And those consists of a type 1, type 2, type 3 collagens and glycosaminoglycan. And these collagens have the structure and elasticity support to the meniscus, and glycosaminoglycan has a structure support, and that's glycosaminoglycan attract water outside the cell. So the inner 2/3 are more deformable than the outer third. So that's important. The deformable, as much the more than deformable it will be, it can restrain more of the force, and it can be from the injury to the meniscus. Vascularity and the nerve innervation, that's another important area. It is mainly from the medial and lateral, inferior and middle geniculate artery. That's an important aspect of the blood supply of the meniscus, and it is have its blood supply at the perimeniscal blood tissue. If you see this meniscus, this is the peripheral zone, which we call as a red zone, and then the central zone is a white zone, avascular zone, and in between these two, it is known as a red-white zone. So this helps us when later Dr. Masood Saab, other colleague, we're going to talk about it, okay, which zone, how it need to be repaired, it need to be trimmed, or what should be the plan of action. So this zone will going to guide us, okay, in which zone there is a tear, and what should be technique, and what should be a plan of action for that. So that's another beautiful slide that was being taken from a 21-week-old human meniscus, and that show the vascularity of this meniscus. That's black show that, and another slide shows also the vascularity over here inside the medial meniscus. So mechanics, very important for the knee joint. We know when the flexion, there is a translation, and then whenever there is a translation, there is also there's a posterior translation of the lateral and the medial meniscus. The lateral meniscus translate more than the medial meniscus, because medial meniscus is tightly attached to the posterior capsule synovium structure, whereas the lateral meniscus is not tightly attached. So that's why medial meniscus, because of the tightly attachment, whenever there is a ramp injury that happens on the posterior medial side of the knee joint and at the junction of the meniscosynovial area. So because of the tightness, that is where the medial meniscus with any twisting injury cause some type of tear inside the medial meniscus. So this beautifully shows on the flexion, it shows how much lateral meniscus is being posterior translated, 5.6, as compared to the medial side, it is around 3.9 mm, because of this that we discussed about his attachment with uh, posterior capsule. Another slides about the geometry of the meniscal motion, and that's an important point that we all know. Medial tibia plateau is concave, while the lateral tibia plateau is convex. Because of the concave structure of the medial meniscus, of the medial tibial plateau, whenever the knee is fully flexed, that is where the medial meniscus is crushed into the tibial rim, and this shows a very beautifully. That's what it means, the full flexion where the meniscus goes. So joint stability, what the meniscus role is in the joint stability, has it any function to cause in the stabilization of the knee joint? And that's for the anterior knee, anterior draw. If the medial meniscal posterior horn stabilize anterior draw in anterior cruciate deficient knee. So if the posterior horn is intact, so it can have some stability in those with ACL deficient, and for those with the meniscofemoral ligament are secondary restraint to posterior draw. And for the rotation, meniscal construct have an important role to prevent in the tibial rotation injury. So this very nicely present to how the meniscus equally distribute the load on whole of the knee joint. If you see that meniscus have work as a shock absorber, it causes equally distribution, and this diagrammatic this presentation about it: increased contact surface area, reduce contact stress. What happened if there's a meniscus present? So this whole of the area is being equally distribution of the weight. If the meniscus is absent, this is only the one contact surface area, and that stress around 200% more at that area. So that's the importance of the meniscus inside the knee joint. Tensile property of the meniscus, that's also very important, how much it can sustain any force. Or so that shows its tensile strength is less. It's around 100 to 110 as compared to the other ligament, which has 300, and the patellar ligament is 500 to 700. So it can lead to damage to some even if there is a lesser force as compared to the damage force required for the ligaments of the knee joint. So lower transmission. So this is another important important concept of meniscal hoop stress. In this figure, if you see, if when the force over here, it has been distributed equally, circumferentially, and then peripherally, and that is meniscal hoop stress. And 70 to 99% of the joint load is carried by the meniscus, and that's a very important concept. Okay, whenever there's a tear inside the knee joint, that tear need to be repaired, because it's having a bowstring-like mechanism. If this tear is going to happen, the meniscal will not going to function as a whole. So that doesn't mean the one part of the meniscal, if it is remaining, so it's mean it's going to function the same as a normal meniscus. Though the whole of the meniscus have to be retained and has to be in collaboration, so the function of the meniscus can be achieved. So by this end with my topic about the anatomy of the meniscus.
Well done, Abe.
Thank you very much. That was very exhaustive.
I think an important point you raise is the amount of translation that the normal meniscus traverses. Do you have any comments on how much movement is an abnormal movement?
Honestly, I haven't come across with this the abnormal movement of the inside that should be counted as abnormal.
Because there is a pathology, especially of the lateral meniscus, where a patient will get locking, and you think the MRI is normal. Mm-hmm. You do an arthroscopy because you try everything else, and it still looks normal. And it's really important at that stage to actually assess how much movement the lateral meniscus has in particular. And there are some that will travel more than you show the normal ranges. They'll come into the joint. They'll come up to a centimeter into the joint, more than 6 millimeters into the joint. And then you have to stabilize those. I think the other thing is with meniscal root tears. So Leprard has defined more than 3 millimeters of extrusion, not including osteophytes, as a problem. And there again, that's too mobile, and you've got to worry about, particularly in the root tears, as you so eloquently showed, root tears are extremely important to notice. And there are two age groups with the root tears. One's in their 20s when they have the ACL, PCL injury, and you should repair them at the same time as your reconstruction. The other is the 50-year-old group, who they're the typical ones that come to our clinic who have a twisting motion with the knee inflection and their hair pop at the back of the knee. And what they do is they have a root tear, and it's often missed. It's only in the last few years that we've now picked this up. The importance is that if you don't repair that root, they will have a rapid degeneration into osteoarthrosis. And then the other problem they can get is osteonecrosis. And I'm sure Masood and Masab will go through the tears. I don't want to steal his thunder, but it was just within the anatomy, I think we should distinguish also between root tears and the rest of the tears. And also normal translation is present, and be aware of it. And if it's excessive translation, wonder whether it's these intermeniscal ligaments that we don't really see, whether they're torn, and therefore we need to stabilize the meniscus in its whole. But that was very comprehensive, and thank you very much for all your hard work in that presentation.
Can I ask a question, Ahmed?
Yes.
So one of the MCQs that everybody is getting worried about is a knee cannot tear itself unless there is rotation in the knee. The meniscus cannot be torn unless there is rotation in the knee. Is that correct?
In a way, the knee is a driving force, so there has to be some rotation on the whole. So I would probably agree with the fact that there is a rotational element, because there's a rotation element in the natural movement of the knee anyway, if you take it down to a very, very basic level. If you have a locked knee in extension, then with big hyperflexion, you can tear your meniscus, but there will be an element of rotation as well. It's very difficult to get pure translation in the coronal or sagittal plane in the knee, just because of the shape of the knee. With again, Kazim had shown that you convexity on one side, concavity on the other side. Naturally, as soon as you come off the contact point, there has to be a rotation. So that's what I would say. Anything is possible, but I would find it very difficult to believe that there was absolutely no rotation.
Okay, good. Thank you. I just want to check, Javed, can you talk to us and see? Sorry, I can't hear you, Tariq. I know you're asking a question, but somehow your sound's not coming.
No, I wasn't. Can you hear me now?
Yes.
Yeah. No, just an observation. Assalamu alaikum, everybody. Sorry. Just an observation. If you notice, the meniscus and the labrum in the shoulder share geometry, and it's obviously a successful engineering principle shared throughout the body. You've got a curved surface on a flat surface being stabilized by this meniscal stroke labral shaped structure. And now shoulder surgeons have at some point started using meniscal transplants for really worn labrum with some limited success. And I think the other one, Amir will put me right on this, or Manova, there was a study soon after the Second World War, wasn't there, by somebody from Oxford, where they showed that the removal of the meniscus had led to everybody having osteoarthritis.
Correct.
Yes.
Can
I first,
Yeah.
Can I commend you on trying to hijack a the knee talk by bringing the shoulder? That is very commendable. Your shoulder through it. That's why you're an amazing shoulder surgeon. So.
No, shoulder surgery, I understand, is becoming defunct now. So
yeah, exactly.
But we're all contributing just to make this a success. You know, we have 15 participants. We can't be bad, isn't it? Like, you know.
Yeah, exactly. So I know you want to. So I first like to commend and congratulate you on your attempts. But you're absolutely right. If you take out the meniscus, you have very, very rapid degeneration, and this is especially in the 50s. So we say, and so far, 20 years ago, when I started seeing arthroscopies, the standard thing was no X-ray, no MRI. If anyone comes with any symptoms, you take them to theatre, you find something, and then you take practically the whole meniscus out. And those people have come to degenerative changes, and it's quite a rapid degenerative change. So absolutely right, and there have been lots of papers since then as well. Yeah, and it's especially the root tears. And the problem is identifying the root tear is not easy. You have to have techniques of being able to see the root, going behind, looking for ramp lesions, then looking for root tears, and then be able to repair them. So it's a completely different way of looking in that part of the knee. And I think what it needed as an urgent is a revision of all surgeons about how they inspect the knee, and make sure you document the root extremely well, and look for ramp lesions. It is tricky because you have to have a few new maneuvers, but I spent most of last Monday with a cadaver trying to demonstrate this, and you'd be amazed how excellent surgeons that I would let operate on me still can't get access to the back of the knee that's needed to repair the root.
Azim, can you take your slide off and let Masood Saab put his slide in, so we can start going with Javed? Can you just say hello so I can see if we can hear you or not? Yeah.
Hello, Assalamualaikum.
Okay.
This is Javed Iqbal from UK.
Okay.
I'm not sure how to put the slides on. You have to guide me. Can you hear me?
Yeah, I'll allow you to do it. All I tell you to do is share. You just open it and put it on your computer, but let Masood Saab do his talk first, and then we'll come to you then, all right?
Okay, thank you.
Masood Saab, your show. We still can't hear you, sir.
We can hear it.
We can hear it. आपको मेरी स्क्रीन नजर आ रही है?
आप तस्वीर नजर आ रही है सर? आपकी तस्वीर भी नजर आ रही है, अब अपनी स्लाइड्स भी डाल दें।
स्लाइड्स मैंने ऑन कर दी हैं। How do I make them? करना पड़ेगा। इसके लोअर स्क्रीन के ऊपर there is a green icon है शेयर का। लोअर आइकॉन के ऊपर से ग्रीन कलर का है आइकॉन शेयर का, उसको खोलेंगे तो यू विल कम अक्रॉस मेनी ऑफ द आइकॉन जिसके अंदर आपका प्रेजेंटेशन जो है वो आ रहा होगा, उस पर जाके क्लिक कर दें। आ गया? मसूद उमर has started screen sharing. Double click to enter the full screen mode. Yes, sir, we can see your presentation now. अच्छा, आवाज आ रही है आपको? थोड़ी सी लो है, थोड़ा नजदीक हो जाए माइक को, या माइक को नजदीक कर लें, but you can start, sir. अच्छा जी, बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम to all. वालेकुम अस्सलाम. Okay, sorry for this bad start. Meeting. I'm not able to move forward now. What should I do? Is this the first picture of your slide, sir? Yes, that's right. And you've gone into presentation mode from your your PowerPoint.
You press something. Tariq Saab, you're the picture now. We need Masood Saab to show us pictures, yeah?
Am I in the picture?
You're the main picture. You must have started share.
Right.
Yeah, we've
So
got
now.
Now we've got Sufyan.
There you go, sir. Now you go into presentation. You ऊपर slideshow है ना, उसको click कर दें.
वो slideshow से फिर वो change नहीं हो रही
चलो ठीक है, इसी तरह कर
है.
दें, इसी तरह कर लें सर.
अब हो रही है?
जी बिल्कुल हो रही है.
या ओके, चलें शुरू करते हैं. हिस्टोरिकल एस्पेक्ट जो आई थिंक काजिम ने कुछ कवर कर दिया. आर्थ्रोस्कोपिक मैनिसेक्टमी for displaced semilunar cartilage, very originally described in 85, then by Japanese in 79, and so on and so forth. So function we'll skip as Kazim has covered that. Load distribution. So, and then now coming directly to the talk of injury and injury with rotational force on a partially flexed knee. That's the most common history given by patients. And the most common site is the posterior horn. Longitudinal tear is the most common geometric type. And length, depth, position of tear all depend on the position of the meniscus in relation to the condyles at the time of injury. So ये एक छोटी सी वीडियो है जो will show you most common mechanism of injury, a twist and a valgus force. So indicating a twisting injury, stretching injury to the medial collateral ligament, as well as twisting injury to the medial. Arrangement of fibers also discussed by Dr. Kazim and blood supply. So I guess we will skip that. I'm sorry for the overlap, but I guess whenever there are multiple people, this can happen. So now the morphological classification. The longitudinal tears, oblique tears, the degenerative tears, radial tears or transverse tears, and then horizontal tears. So and then there can be flap tears and bucket handle tears, also in either of the lateral or medial meniscus. Just by morphology, this is a picture showing a longitudinal tear, which if extends and remains untreated can extend into a full-blown bucket handle tear. MRI classification, again, grade 1 is an intrasubstance tear, grade 2 reaches to one of the borders, and grade 3 extends to the articular surface. And now some MRI pictures, complex peripheral tear of a medial meniscus in the right knee joint, showing as an opacity in the normal, otherwise black triangular portion depicting the meniscus. And again, coronal and sagittal views showing the meniscus, posterior horn tear. Same view. And now meniscal extrusion. Whenever there will be, as we were talking in the last discussion about root tears, there will be a classical ghost sign, a meniscal extrusion, absence of meniscus, and the third MRI picture showing the classical meniscal root tear. A broken bow tie sign. Normally a meniscus would appear as a bow tie. As you can imagine, the cuts A and B being observed on the
coronal, on the sagittal views as a bow tie. And if there is a bucket handle tear, you would have a broken bow tie appearance as is shown in the cut B and picture on the right. So a classical double PCL sign on the MRI of that of a bucket handle tear. Truncated cartilage sign revealing a radial tear of the lateral meniscus in this picture. A ghost sign again can sometimes be indicative of a big radial tear. Cleft sign of the left knee, lateral meniscus again indicating a radial tear. Then there Isakos has devised some classification systems according to rim width of either of the medial and lateral menisci. So I think more for academic and regulatory reasons, where the tear is located according to the width of the meniscus. And then where is the tear located according to the anatomical location, either it is posterior or anterior or mid-body. And Isakos classification of the same morphological tears that we observed previously is also shown here, more or less the same: horizontal flap, vertical flap, radial, and then horizontal and vertical tears as shown in this picture. Discoid meniscus, very rare to see them, but you see them. Maybe in the last 15, 20 years, I have operated maybe 7 or 8 up till now, discoid meniscus. So maybe 1 in 2 years, we get to see them and operate on them. That's the classification. It can be a full discoid, half discoid, a quarter discoid. Degenerative tears have also been classified as are shown here, from a type 1 simple fibrillation to a complex lesion in type 5. Depending, they can have a flap in between and a component of horizontal tear also in between. Roots, as Amir Saab was just touching upon, root tears. So I have a separate presentation on root and ramps, but just for the sake of classification, the classification of meniscal roots, type 1 is partial, 2 is complete, 3 is with a bucket handle tear, 4 and 5 is with a bony avulsion. Classification again of ramps. That's the normal meniscotibial ligament, a ramp lesion appearing here as type 1 inferior, type 2 is partial superior, type 3 is partial inferior, type 4 is complete superior, and type 5 is a inferior. Now, so much so for classification. What are the clinical features of an acute meniscal tear? Physical exam, the most consistent finding is joint line tenderness, as is being shown in this picture, along either medial or lateral joint line. And for juniors attending this session, one should be able to identify the joint line, which is very important, especially in obese patients, that where is the joint line, especially in relation to the patella, which is kind of much easier to palpate even in an obese patient. I was able to find this picture today. We talk about him a lot. So full name was Thomas Porter McMurray, a British orthopedic surgeon who died in London in 1949. And the McMurray's test was described in 1942. So that's how it is done. We are fully aware of this. I started usually in a fully flexed knee and click or a pane, full maneuver. and resistance of the patient is usually indicative of a tear. Can be done prone also. Meniscus diagnostic test, which is called APPNE grinding test, always required for an FCPS2 student to demonstrate at least 2 tests, which are McMurray's and APPNE grinding test. In a prone position, you hold the foot and rotate. You compress the leg down sometimes. Elicitation of by the patient is indicative of, again, a meniscal tear. Thessali test is when the patient is standing on a single leg stance. The examiner holds the patient with both hands. It doesn't fall. The knee is partially bent and the patient rotates internally or externally, and any signs of pain are predictive of a meniscal tear. Again, a Steeman's test where the patient is sitting on the edge of the bed or chair, the knee bent at 90 degrees, and the examiner in a bent knee rotates the tibia externally or internally, producing pain. A modified Helfet test, again, patient sitting at 90 degrees. Normally, the tibial tuberosity should be in line with the lateral edge of the patella during extension. If it doesn't go in that line, this is indicative of either a meniscal or a cruciate injury and warrants further investigation. Now, is there any role of non-operative treatment? And what do we do in an immediately patient who has come with an immediate injury? Acute episode without locking, but with an acute synovitis with effusion requires immediate abstinence from weight bearing, rest with knee flexion, application ice pack, compression, and the RICE protocol that we usually follow. So the good algorithm for any suspected or proven meniscal tear of when to do non-surgical management and when to embark on a meniscectomy, arthroscopic meniscectomy. So a symptomatic tear, which patient has pain, we should consider arthroscopy. If they're not symptomatic, we can have physiotherapy and follow-up. And if we're considering arthroscopy, if it's red-white zone, patient is under 40 years, it's reducible, we repair. If it's patient is adult, it's more than 40 years, usually do a resection. If it's white zone, we do a resection. If it's red zone, reducible, we repair. And if the patient is more than 60, we resect. So that was a useful algorithm to understand the indications of meniscectomy and repair. Some people would also prescribe a cast or knee mobilizer for 4 to 6 weeks, crutch walking, non-weight bearing, progressive isometric exercise in the cast. And after 4 to 6 weeks, you go on to proceed to rehab and muscle strengthening exercises. Most important, restoration of power. Now, the big question will be repair, resect, or leave alone, and recognizing what to do with meniscal tears. Meniscectomy, as Kazim also touched upon, is removal of, it says, 30 to 80% of meniscus, changes the load bearing and leads to late degenerative changes. To preserve the meniscus, protects the cartilage. How bad is meniscectomy? Is the commonest arthroscopic procedure performed. Only about 20% of tears are amenable to repair. And what are the long-term consequences of meniscectomy, and does repair give a better result? Meniscectomy published hugely in the past. Partial meniscectomy reported at 11 years post-op. 22% had degenerative changes. 12-year result, 50% degenerative changes on X-ray. 5 to 15-year follow-up, 78% degenerative changes. 8 years after ACL reconstruction, repair was the same as resection of bucket tears. Indications for repair, very strong indications, peripheral red on red or embarking on red on white zones. A relatively shorter tear, a vertical morphology associated with ACL tear, an acute tear, and especially in a younger patient, would constitute strong indications for a meniscal repair. So literature also tells us that only 20% are repairable, the rest end up in meniscectomy. Now the big question is, what is unstable? How do you define unstable and subsequent treatment in terms of repair or resection? When tear length is more than half of the meniscus, when it subluxes under the condyle with probing, that is usually a good definition of an unstable meniscus. Definition of degeneration, there are horizontal cleavage tears, meniscus rolls when you probe, delaminating of the fibers with shredding of the meniscus, and radial tear in a bucket handle, in a pre-existing bucket handle tear. Sometimes you can even leave them alone. Lateral flap root tears, undisplaced stable medial lateral meniscal tears. Short undisplaced stable medial and lateral tears can be treated with synovial abrasion alone. Short stable tears can be treated with trephination. So different people having different recommendations for leave alone meniscal tears. So identifying the tear as a beginner for knee arthroscopy, which some of the viewers here may be today, we need to use our hook. And as Amr Saab rightly said, as you grow old, we need to identify complex tears and in terms of ramp lesions also, and we need to be able to put our scopes in difficult positions between the PCL and the medial condyle, sometimes behind the PCL to identify the lesions. Then use of power shaver. Meniscectomy can be termed as partial or subtotal, as is depicted in these diagrams. So a very quick video of a partial meniscectomy.
It's not working, Masood Saab.
Jay?
It's not working.
Not playing.
Not playing?
No, sir.
Okay, it was playing on my screen. Anyway, we can skip. It was just a video to show different types of tears which should be resected. So then complications after meniscectomy, post-op hemarthrosis, synovitis, even fistula formation, and sometimes where the patient bugs us much is when they develop reflex sympathetic dystrophy like symptoms, persistent effusion, pain, and decreased range of motion. Late changes, degenerative changes, people have described narrowing of joint space, flattening of peripheral half of the articular surface, development of ridges, and all indicative of degenerative changes. This we all know, resectability of meniscal tears from the red zone to red to white zone. I guess, Munawar Saab, we have a presentation on meniscal repair. So I had added slides for repair also. So if you want, I can continue, but the rest of the slides are on repair.
Yeah, Javed Bhai has got a very amazing presentation on meniscal repair. So if you let Javed Bhai do it, if something's missing, I'll come back to you then, if that's okay with you. Yes.
If I could just comment to that again, Masood Bhai, as always, you've been extremely thorough and the voice of experience as well. Just to go on about first the clinical examination and tests, and of course it's as surgeons and doctors, clinical examination is going to be paramount before investigations. I think we can safely say the APPNE's grind test and McMurray's is very historical now. And I think putting the patient through such a provocative test, it will fail you in the FRCS Orth exams for sure. Thessaly's test, on the other hand, is still very, very appropriate because the patient is in control. So what you do is you ask the patient to hold out their hands and they rest on your hands, and you have the 20 degrees of flexion and you get them to rotate, and then they can't and they feel the pain. So I think Thessaly's test is something that I use and I record, but I think it would be good if the senior surgeons who control the curriculum of the FCPS could maybe remove McMurray's and the APPNE grind test from the exam, but I leave that to you senior guys. So I think that's what I would say in terms of the examination. You raised the discoid meniscus question. Now, I tend to see it a bit more often, and maybe that's the ones that are hypermobile that I was talking about, maybe they are a form of discoid meniscus, because embryologically it goes at apoptosis. When you've come across discoid meniscus, what have you done to them, Masood Saab? How have you treated discoid meniscus?
If they are symptomatic, I have resected them, and out about 6 of them, and 2 I did repairs. They had peripheral tears also. I cleared the discoid part of it and repaired the peripheral part.
Because
so it was a combination of resection and repair.
So because there is the problem is that there is an incidence of increased osteoarthrosis with the discoid meniscus. And it is sometimes difficult to see, well, what do you resect back to? And the other problem that the discoid meniscus is that the anterior horn is detached. And that's very, I won't steal the thunder of how the meniscal repairs, and maybe we could talk about it at the end of the meniscal repair talk. But you have to be very, very careful in detecting and the anterior horn tip, because that then you have to repair back. And it was just this week, again, I had a MRI report showing a lateral meniscal root, lateral meniscal tear. I couldn't see it. I probed for about 3 minutes and I couldn't see it. Then I switched portals, and then there it was a radial tear. So sometimes when you put your anterolateral scope in, the tear can be right underneath where your traditional portal is of your scope. So the other thing I would say about the tear is if you can't obviously see a tear, the MRI shows a tear, just switch your scope. And so those are the 2 points that I thought, mainly to confine McMurray's and APPNE's grind test to for knowledge rather than practice, reinforce Thessaly's and the discoid meniscus. But I learned a lot in that talk. Thank you very much.
Sorry, just to confirm, while we're talking, can Masood Saab, can you take your presentation off, and Javed, can you load your presentation? Just on what Amir said, I do also some examinations for the FRCS orthopedic. If you see a person having a strain on his face, that's a clear fail. So I agree with what Amir is saying. In this part of the world, you cannot do these historical tests. If you do, you're a plain fail, like, you know. So maybe it'd be worth having a chat with the senior guys, people like you, Masood Saab. you can tell them that this is something that the world is not looking favorably on, like you said. But, Javed Bhai, can you load your presentation, please?
But that's at
Then
least
I am the junior most person, but anyway, I'll pass your message out to the rest of the examiners. I agree with what Amr Saab is saying.
I think most of it's from the history. You sort of know what the diagnosis is. The difficulty is sometimes between an MCL and a medial meniscal injury, and it's still good to record in the notes. And Thessaly's test, I think, is still appropriate, and it also gives an idea of the muscle tone. The other thing that I think it's a debate, and I'm not saying that it's the absolute right answer, but non-weight bearing is an interesting concept, because if you see in a practical day-to-day life, it's extremely difficult to non-weight bear. And within 10 days to 2 weeks, you can already see the muscle wasting because people are not using it. And there's a fear, as soon as you tell someone don't bear any weight on, there's this immediate fear for them to even move the leg. So it's difficult, and I understand why you would not want to weight bear. But the way that I have got around this, I say, move on 2 crutches, put as much weight as is comfortable, but go through a full range of motion. And in that way, they know they have to keep mobile, but with 2 crutches all the time. And then because they get quad inhibition very, very quickly, and you don't want to allow that to develop. So that's what the other thing is about the weight bearing status. I send them immediately to the physio. If they're a private patient, they see the physio the same day. If they're NHS patient, they see the physio within that week. And then 2 crutches, they leave the clinic with 2 crutches.
Amir Saab, if I may ask a question.
Yes.
What would be your indication for non-operative treatment of an acute tear?
I think older person, over 35, even maybe over 30, because the results of repair do decline over 30. Knee that has a full range of motion. So if at any age there's a locked knee, I think a locked knee is a knee emergency, and we have to go in soon. Immediate MRI and locked knee. And then just a trial of, I think, at least 12 weeks of physiotherapy for non-operative treatment. As soon as I have a locked knee, I would go in straight away. So if you say indication for non-operative treatment, patient over 30 with a full range of motion in his knee, progressing well with physiotherapy.
Can I put a shoulders surgeon's view on the knee then? You know, this non-movement business. Yeah, the VMO stops functioning within 6 hours, right? And the VMO actually tells the brain whether you're standing and sitting. So it's a very complex process, but it tells the brain whether you're standing. So therefore, the knee does not understand, or the brain does not understand, and gives up. And that's the commonest symptom people have from not moving their knee, is they feel insecure and they can't put weight on their knees. So I do not recommend, completely stopping the movement, as Amir said, but you should have some sort of function, otherwise the knee will totally be wasted.
Yeah. So the reason for the non-weight bearing is mainly because especially if you've got a loose meniscus, as you flex the knee, it gets squashed and the blood supply, and you risk extending that tear. And obviously, as Kazim has shown, that the meniscus is mobile. So the more you load it, the more mobile it'll be, the more you're going to stretch it, and the less chance for it to heal. So I understand the argument for non-weight bearing. However, there's got to be a balance. So I think as long as they don't stop moving, and you don't want to hyperflex more, you don't want to flex more than 90. So you don't want them to flex more than 90. You don't want them to put too much weight on. But equally, you don't want them to be so scared that they don't move their knee at all, because the synovial fluid then stops moving around. The blood supply is actually worse, and the results will be worse as well. So it's a very fine balance with lots of conflicting points.
So Kazim is asking a question. Last question, Kazim, and then we go to Javed Bhai, yeah?
You have to help me how to load the slides. I'm not getting through.
You will see share underneath it in a green, you know, where you are on Zoom, there will be a share which says a green emblem.
I'm really not finding. There's a more chat, participant invite, stop video and join.
If you say press share, it will show your desktop.
If you're using touch screen, you have to touch it. It will appear.
Touching. So there's a number. My audio is coming.
Yeah.
The problem is my audio is through the phone. Yeah.
Just touch it. It will appear down.
Down here.
Yeah. Yeah. Just touch the screen. Just touch the screen. It will appear.
Qasim, you have another question?
I think there is one pending question from Mr. Amir Jalil that he is asking that could we can do the Tesla test with collateral ligament damage?
Well, if the collateral ligament is damaged, the patient won't be able to twist. So then they won't be able to do the test, and then you say a bad job, and you don't provoke it any further. So any test that the patient themselves initiate the movement, that's a safe test, and they won't be able to stand on one leg and flex at 20 degrees. So then you know that the injury is much more than a meniscal injury.
Can you get it sorted, Javed?
You got to help me.
So,
I'm really.
Okay, Javed, why don't you ask Javed to send his presentation over to you and you play it from yours, and then he can talk over it if that's what we need to do.
Can you find a share button underneath it?
No, it's just
touch your screen, it will show you share, and if you press share, the PowerPoint will come.
I'm touching the screen, and can you see me? I think you can see my video, and can you hear me now?
Yes.
Because I have connected my audio through the phone. And it's just a share.
Maybe your video is closed. You have to turn off your video. I think you have to turn on your video.
No, this is my video, which I just switched off now, yeah. And now it's switching on. Can you see me there?
Yes.
No.
So video is on, audio is on. It's just the presentation now.
Have you got your PowerPoint? Have you got your PowerPoint open?
It is on the MacBook Air, which has got Keynote.
If you press play.
Play on the presentation. Okay.
And then if you touch the screen in Zoom.
Okay, so this is the presentation in Keynote. Yes.
Yes, and if you just share it says share
play on this Mac. So this will play on the Mac, is it?
Yes.
Can you see,
can you
see that?
Yes, so if you go to Zoom.
Okay, so you can
go back
see
to
this.
your icon that says Zoom and press share content, which is the green type of button.
Okay, so the play is there. Play on this Mac. Can you see this? Hello?
No.
Oh, God. No. Oh, gosh. The share icon is not coming on the Zoom.
Okay.
Why don't you just talk to us then? Doesn't matter about the slides. Why don't you just talk to us about meniscal repairs?
That will be so boring. Where is the...
Okay, so basically, in terms of while you sort it out, I'll start.
Can I say something, Amir? I have a very small, very provocative presentation on stem cells and
So you're always provocative. Let's stay with the repairs for now, and then give me 5 minutes of repairs, and then you can do your provocation. In the meantime,
I'll be in a new meeting and not stir it up like.
Good morning, guys.
Okay, so good morning. So in terms of repair, the way the techniques are, you can go from the outside in, all inside or inside out. And most of the commercial mechanisms that are available, such as Fast Fix or Arthrex, they're all inside. The all inside repairs make it easy for us to earn our money. They deploy quite easily, but there's only a certain region of the meniscus that you can actually get with the all inside. They normally have peak anchors. There's some heavy breathing going on.
No, that's Umar Butt doing his morning run. So I have just.
I'm so sorry, guys. Sorry.
I'm really sorry.
Okay,
I'm having big difficulty. I don't know how to do this.
It's all right. Just do it some other time. But let's hear what Amir has to say.
Amir, I'm so sorry. It's Sunday. I have to run. You know that.
Okay, you're a fit man. That's the secret to your handsomeness.
Okay.
Okay. So that's the all inside. They normally have anchors. Now, what the way to use them really is the best tears are the horizontal tears to repair. Radial tears are more difficult, and there should be a sequence. And it's you've got to try and get more blood supply. And whenever it's going to stir things up by how you get the repair. But the way to get that blood supply is you can just use a needle. And in fact, there are people now, when they've had bucket handle tears, they think that the reason that the bucket handles are tearing is because people like me are putting 8, 9, 10 sutures in. And it's probably not the suture that repairs it, but it's the new blood vessel channels. So I've spoken to at least a couple of surgeons now that just get a needle and do many holes in the meniscus and don't put any stitches in. And they say that they've had good results from that. They've not published it, so I'll wait till the publishing comes. Then what you could do, remember, say if I talk about the Fast Fix anchor, there's forward anchors and there's reverse anchors. So what you do, you put all your forward anchors first, and what you'll see is that the meniscus will lift up. Then where it lifts up, you've got to put the reverse anchors from underneath. So they both cost the same amount of money, the forward and the reverse, but you have to have both available. Now, the other thing is the cost of these anchors. So the cost of these anchors probably make them unaffordable to most places in Pakistan, to most patients in Pakistan, because each one of those costs about £180, and you're using 7 to 8 of them. So then comes the technique of outside in or inside out, and then that you can have sutures. Now the inside out actually has a there is a kit. There's a reusable kit, and you can get it from Smith & Nephew. You could get it from Arthrex. And what you do is you use these tubes, and you have to get used to portals. The metal tubes, you put 2 tubes side by side, and then there are 2 needles with the suture connected. So you pass the needles, and then that places the stitch. Now the difficulty then is the anatomical considerations. So as you're going towards the back, you've got all the vessels. So what you have to learn to do is create a safety portal. So you create a safety portal in the medial and the lateral side. You then use a spoon or whatever you need to do to protect the neurovascular structures. And when you put the needle out, you have your assistant pushing the needle in, and you seeing the needle and dragging it out of your safety portal. You get all your sutures through that safety portal, and then you tie them one by one. And you have to have lots and lots of sutures. Then when you come very, very anterior, it's difficult to put either all inside or inside out very anterior. That's when you have the outside in technique. At the very cheapest level, you could put 2 Venflons in and then use a hook to try and get this back, but it becomes very difficult. There are things called the meniscal mender that are relatively cheap, and that does the same thing. So you just got to have the technique where if you're using just cannula or Venflons as we take them, put a loop, and then taken the suture through, pull them out, and then tie them through a safety portal. You've got to be careful of the saphenous nerve as well, because you can sometimes catch that. All these techniques have to be rehearsed. Now, the important thing is how you get access. So on the medial side, it's extremely important to know how to do pie crusting of the medial collateral ligament. And that revolutionized my life when I learned how to pie crust, because suddenly everything becomes accessible. And the way to pie crust is, hopefully, inshallah, one day I'll be able to demonstrate in a cadaver to you, but you put your scope right into the posteromedial border and you see where the light is shining. That's around the area of the MCL. You then get a needle and you've got to try and just make one hole on the outside of the skin. If you make multiple holes, you have your chance of infection increases. So one hole, and then you go through the MCL a number of times while you're putting a stress on. And you see suddenly after about 20, 30 seconds, you'll see everything, the space increasing. Now be very, very careful, because sometimes it'll go pop and then you've done a proper good release of the MCL. If that happens, don't worry, don't stress. Just put them in a brace afterwards for 12 weeks, like for an MCL injury, it will heal up. So then the thing is, as Masood Bhai said, who to repair and who not to repair. Kazim showed the red on red, there's the red on white, and now, to be honest, with the younger people, I will even try white on white. Mainly more for the lateral than the medial, because the lateral meniscus is more important than the medial meniscus. So that's a non-slide summary of meniscal repairs. So to summarize, get access to the knee. That includes pie crusting.
I have few slides if you allow me, Munawar Sahab.
Yes,
that'd
be great. So you pie crust. Then to get to the root, you have to go alongside the ACL or the PCL. Then there's very important portals to learn is the posteromedial and posterolateral portal. To create the posterolateral portal, you go through the anteromedial incision site, go past the ACL and look around, and then you put a needle in and then you make the hole. Same for the anteromedial, you go put your scope through the anterolateral, go past the PCL, look at the posteromedial border and put a needle in. Now, what a lot of people forget is the septum. There's a septum of the posterior compartment. So the border is the back of the PCL, and it attaches to the capsule and it attaches to the roof at the top. So if you have your camera in the posteromedial portal, you cannot see across the knee to the lateral compartment. You have to make a hole through. And then you make that hole through by doing your portals, putting a 1.5, so you've got your camera in your posteromedial portal, through your posterolateral corner portal, you put a 1.5 K wire, you then put a 3 millimeter K wire, then you can put your shaver through. And then you'll be seeing the whole back of the knee. And from that, you can do repairs at the back of the meniscus as well. So that's a quick summary. So open the joint up, get your portals, and then all inside techniques if you live in a country or you have access to all inside sutures. Otherwise, get yourself exactly as has been shown there, these probes which you could pass the sutures through, and then also get an outside-in meniscal mender. Thank you very much, Masood Bhai, for taking over. It'd be great to see your slides now.
So, Masood Bhai, just keep it short. I mean, Kazim, Ahmed has done it all. This is just quickly show us the videos or the pictures you have, and then I want to make it a bit controversial. I always wanted to do it, so I need about 10 minutes after that. Yeah.
Can you see my screen?
Of course, we can see your screen, sir. We can see your screen and we can hear you.
Yes.
So this was the spatula and this was the tubes that Amir Sahab was talking about. I usually use 2,0-proline and now PDS. And this is the interval we need to create. We need to be behind the capsule and between the gastrocnemius and capsule, very fine interval, very easily identifiable interval, but you have to know where to give the incision to put your spoon. So if you don't have the spatula, and we have done that, autoclave a teaspoon and put the teaspoon between the gastrocnemius and the posterior capsule. That's where this is my own patient. And to add to the theory, this interval is created by this incision. You just go bluntly, you don't need any fine instruments. Even with the finger, you can find this interval. Once you have cut the deep fascia, the interval between the gastrocnemius and the posterior capsule. That's where your spoon would go, and that's where your needle would hit and curve back and out after hitting the spoon, and your resident can pull the needle out. So that's the appearance of the needle on the picture on the right bottom, the first needle. Then the surgeon or the resident pushes from the top. It's a double-barreled tube. The two needles are put with the same suture with loop at the top. And this is now multiple sutures coming out of the same portal. And usually I prefer vertical sutures for a longitudinal tear, as shown in the picture, and multiple knots are taken. And this is the final post-operative picture. This is one of my patients, more than 10-year follow-up, a Turkish teacher living in Pakistan. She had both medial and lateral menisci injured, and I repaired both of them. And this is the functional result of her knees. She was able to squat, very happy outcome. She was quite comfortable with her after 10 years of surgery. So,
yeah, I like the shades. Is there a reason for her to wear shades?
You like the what?
The shades, the glasses.
Yeah, so I'll ask her when she comes again. Okay, so what I use is now a 21 gauge needle Amirbhai, so it becomes even cheaper, and a 20 proline suture for an outside-in repair. And learned it from a big man, Michael Strobel, and he showed me how to do it with a 21 gauge needle, and I can do it successfully now. So just 2 needles and 2 sutures are required. And outside in, very effective technique for, I usually don't give such a big incision. This is from the internet, so not my own patient. So two needles, sutures, you pass the loop inside the joint, you take multiple passes, and then you tie them over the interior capsule. So this is outside in, mostly for the interior thing. And then biologics, I would stop. Thank you.
Thank you very much. Yeah.
Stepping in, brilliant. Thank you.
Okay, so shall I become controversial now?
Yes, please do.
Yeah, please take it with a pinch of salt, Amir. Okay, you can criticize it, but let me present it first. Okay. So my presentation is. Can everybody see it? Yeah.
No, I can't see your presentation.
Oh, all right. Okay, give me a second then. Share.
So while Manova gets his presentation up, oh, it's up now.
Okay, so I being a shoulder surgeon, I couldn't take it too long to sit in a knee meeting, so I thought I'd just stir it a bit. Okay, and since the current atmospheric environment is gagging for it and wanting it, I'd put my bit in on meniscal injuries. And you may not need to be a good surgeon like, say, all of you guys. I like Umar Saab or Sufyan or even Kazim or Iqbal Bhai or Umar. So something like this for me as a shoulder surgeon is still valid. And I'll show you what it is, okay? So you must be aware, this is what I feel about, and that's why I do a lot of work on education, because I feel about it that we need to share education. I can't go there, but I can teach. Okay, so the most important thing is the realm is that we have to have meniscal regeneration. That's the holy grail. And how do we get it? There's a limited number of human studies. There are a lot of in vivo studies in animal models, but very few human studies. And this is all catching up. It is all coming up. And the key here is the future is bright. Okay, so we are very close. We are very close to repair meniscus with biologics, because it was always biologic. It was never mechanical. So the meniscus itself has the capability to repair. However, we can't hold the knee long enough for it to happen, because in 6 weeks, if you put it in an environment where there is no mechanics, the cartilage will heal. So it is the unfriendly environment that makes it stop from healing. Okay, and this is the slide that Tariq was talking about earlier. You know, the more meniscus you take out, the more the mechanical pressure is on the knee, and therefore it makes a very unpleasant environment. And therefore there is no chance, or very little chance for this to heal. And it's true, we have to hold the knee together long enough for this to happen. Okay, we can do it another way. We can try biologics. Okay, and this is what I think Amir's reaction to it is. As soon as I've started my talk, like I said, he thinks that we are talking something totally out of the world. But like I said before, I don't want to be a mini-me. I want to be controversial, and I want to be a gambler to try doing things which may help my patients, but I would definitely not try to do anything like this unless I know I'm sure about it. Okay, so what has happened is, because of the cartilage tear, the mechanics is all gone, and there's a toxic environment that kills even the normal stem cells that are present in the body. We have to change this environment for it to heal. Okay, and there's a state of emergency declared in the knee, and the inflammation authority stop everything to shut down secondary structures to divert themselves to vital structures and vital services. Okay, the swelling starts, which causes stiffness and pain, and immobilize the knee to stop the destructive forces. Okay, with swelling, the ligaments are additional casualties of war, and they don't do anything. They can't move because of the swelling is holding the knee together. And because the bone can only understand one thing that is broken and start making more bone, you'll have bone spurs, you'll have locking of the knee, and therefore it stops the knee from moving to protect further bone damage. Okay, and the last and the worst thing on this is that the chemicals present to help you is now dissolving and damaging your cartilage and meniscus. Okay, so this is a slide that I'm sure you guys have seen before and was discussed earlier, the blood supply to the meniscus. And as you go away, the more thin it becomes, because the knee has to glide and rotate and slide, and the blood supply becomes poor and poor. However, you must all remember that the healing does not come just from the blood supply, but the synovial fluid also has enough help to help these cartilages and menisci to heal. This is a very famous slide: the inner zone, the outer zone, the red zone, the red white zone, white zone. And I agree with Amir that if you have a young patient, even in white zone, you should be able to or want to offer repair, because you never know, it will help. It will try to repair itself. And as long as the 1960s, people have been putting blood or fibrin clot on top of the repairs, especially if it's a white repair. Okay, so this is just to reiterate that the innermost zone, which is the avascular zone, is unlikely to heal, and there is no successful proven method to heal it until biologics came into being. Like, okay, so this is one of the few papers. This all started with animals. This was a mice study. This was in the Journal of Orthopedic Research in 2017, right? And you can see this is the control knee of a mice, and they have taken half the cartilage off, and in 3 days it is starting to heal after injection of mice stem cells were given to this mouse. In 2 weeks it is regenerated. At 4 weeks is there. At 6 weeks it's nearly normal. There is a area of contact with the meniscus also looked at. Is the same thing. It's just telling you the meniscus is growing again, like I said. And this is a histological study, and the control cells are exactly the same in 6 weeks with mice who have had a stem cell injection. Then you can see the histology proves that. Like, okay, so another paper from mice we then migrated to rabbits, and from rabbits onto sheep, and this shows a bone marrow being inserted into meniscal tear in experimental studies on sheep. Okay, so if you look at it, they've created an artificial tear, they have a control, and they have an experiment site, and they have injected it with bone marrow from the sheep, not stem cells, but bone marrow, and that cartilage is healing, if you look at it. Okay, and this is at 12 weeks. So there is potential for these cartilages to heal if we give them the right environment. Histologically, if you can see that, this is the tear is disappearing, and you can see normal cartilage taking place. This is now sheep, okay? So we have now gone from mouse to rabbit to sheep. We're now seeing if we can do it in human beings. So the Chinese are always ahead of us. And what they did was they put human growth factor and growth factor fibrin transforming ones. I keep, because it's so basic, I keep forgetting the names, for healing avascular meniscus tears, right? And they felt that in a tear, if you apply these sequentially, you will get the cartilage to remodel into fibrous tissue and to region-specific fibrocartilage tissue with the appropriate environment created for it. Okay, so these are pictures from that study. So they have a cut, the synovial mesenchymal cells appear, and they become a fibrous tissue and then become chondrogenic tissue because of the environment being created for it. Okay, this is a histological confirmation of all that, and it tells you that if you just put fibrin alone, it won't work. If you put fibrin with growth factor, it will work, and if you put the tissue transforming factor into it, it will work even better. Yeah. So another study, this was carried out in bovine meniscus, which is cows, and they put a inner third of it, they cut it, and then they injected with synovial mesenchymal cells, and you can see that the body was providing all these cells that we artificially provided in the first study. Okay, and again, if we look at histology, there is evidence that there is healing, and they all do well. So from here in a cow to this is what happened when we created the right environment, right cells, and the right structures. So this is the first human study on mesenchymal stem cells, and this was published in 2014 in the Journal of Bone and Joint Surgery. Okay, and again, it was a randomized double-blind control study, which is unusual and rare, but they got ethical permission and they put it, and it was delivered intraarticularly via injection to human knee. They distributed patients who had partial meniscectomy because of a reason. So it was not that they did the partial meniscectomy, but they distributed all patients with partial meniscectomies and assigned them into three groups, one into one, so each had equal numbers. So in group A, 50 million human mesenchymal cell was given, in the group B, 150 million, and in the control group, an injection was given just to see what it was. This was not unethical because the major treatment was partial meniscectomy for a mechanical block. So the stem cells were just to see what they will do if they were given stem cells. And this is the distribution of patients. There were equal numbers in every group. They were assessed by MRI scan, and I understand this is one of the problems with this study was that no arthroscopy was done afterwards. They were just looked at with an MRI scan, and the MRI scan was done prior to the injection and meniscectomy, which was control, and they were then done at 6 weeks, 6 months, 12 months, and 24 months post-op. Okay, so the criteria was there should be at least a 15% increase in meniscal volume on MRI. At 2 years, the study showed that there was significant difference in the control group and in the group that had stem cell injections. It was very significantly compared to in the three groups. Okay, so the study said that there was no abnormal ectopic tissue. So if we inject stem cells into the knee, it will not just make different type of cells in the knee, which was very reassuring. What it would do would make a cartilage where you wanted it. How it gets there, don't ask me. I'm going to show the surgeon likes it, but it does get there and makes a difference. And there was a significant increase in meniscal volume. So in 24% of the patient, in the low dose injection, they did really well. The high dose injection did not do well, but 6% also did better. But compared to the low dose one, the high dose one didn't do well at 1 year. So the patient with arthritis experienced a reduction in pain in the stem cell. This was prior to the meniscectomy. Patient that, and there was no reduction in the control group, so which means that the stem cells was making a difference to the knee, which had some arthritis to begin with. Okay, and we know that the control group that had nothing in them actually converted into an arthritic knee, 21% of them, whereas only 6% of the one treated with stems converted into arthritis. So there is some clout in this study, okay? So overall, the pain score also decreased, but not only in the treated group, but even the control group. And we know that because if the pain was because of the locked mechanical fixtures of the meniscus, therefore, when you do a meniscectomy, it'll get better. However, the injection also made a difference. And now whether it was the meniscectomy or the injection that made a difference, we don't know. Okay, and this is the visual analog score of all the patients. So the black is the control, the white is the group A with the very little stem cells, and the gray are the ones with the major stem cells. And if you can see them, in 2 years, they were all better. So this is the key diagram that you have to take from my short, controversial talk. I will show you some more pictures, but this is the key thing. You have to have, for healing to happen, a matrix. You have to have growth factors, and you have to have regenerative cells. So the stem cells are regenerative. The tissue growth factors and the transforming growth factors are the growth factors, and the matrix is something that I will talk to you about now. Okay, so this was another study that was carried out, and this was in 2018, where they looked at torn avascular meniscus cartilage, and they did a stem cell to see if this was going to make any difference by not doing any operating, just stem cell injections. And what they did was they took a meniscal shaped disc, and they used staples to put it together in vitro first, and put mesenchymal stem cells and some growth factors into it, and they started to heal. Right, and this is a picture from that study where the meniscus has actually grown back into the shape that it was supposed to be. But three things can happen. It can be a seamless integration. It can be an integration with CMNet or no integration. There was no way to predict which way it was going to go, right? And these are pictures from that study. And these are sheep studies to start with. Then human, I will show you, they made a cut into it, and the cut heals with the appropriate environment, okay? And this is histology for it. So this is now real time. This is human study of 5 patients. I know it's not much, but it is the beginning, and this is where it all starts. There was a meniscal tear. This was repaired, not from what we've just seen, but with anchors that we have that Amar was talking about. And a gap was left in between, and a small little fibrin of what it was called is a insert was put in. This was like the implant that had stem cells in it, and then it was closed. So we not only have just a repair, but we actually put in a scaffold in there with it. And it started, this is the end result of the repair straight afterwards, okay? And then they had MRI scan follow-up. You can see the tear, you can see that it's getting better. It's even getting better, and it looks like it is increasing the shape of the cartilage, so the cartilage is getting bigger, right? And the final picture, the whole meniscus looks nearly normal, okay? So this is the score that there was failure. So at 1 year, they didn't fail, and they were doing well, the pain was gone, and the MRI scan showed good results. At 18 months, only 60% were doing well, and it stayed at 2 years' time. This is the scores for all these. S means success, F means failure. So there was not a lot of difference between the IKDC score, but the range of movement was better in the success ones. And of course, this other score also made it look better. So 40% times it failed, but 60% times it worked. So you are doing the repair. You don't lose anything by putting the scaffold with stem cells in it, okay? So this is in other journal that was printed not so long ago.
Let's conclude soon now.
Sorry?
You want to conclude soon now?
Yeah, I'm nearly there.
Yeah.
So this is the latest study where they have done the same thing. They are putting scaffolds in it, and they're putting scaffold with the repair, not just the repair, to make sure that it works. Okay, plenty of studies talking about this. But what we need to know is this is where the future is. Now you can grow your own ball and socket joint by making your own cartilage. Okay, so what I would say is watch this space. Don't disregard orthobiologics, because we are being mechanically treating biology. We should be treating with biology. I'm a firm believer. There is enough evidence of that, but we need to be aware that it is not all about money. It is what you can do for your patient and what we can achieve. And it has to be safe. It has to be evidence-based. And we need to make sure that we're doing good rather than bad. So now I'm open to criticism.
No, that
Very.
was very good, and I think orthobiologics is going to be an important part of meniscal repair. It's just got to be more affordable, and it's got to be available. I remember for every single meniscal repair that I do, I'll get the microfracture oil, and I'll microfracture the side of the ACL femoral condyle to release some stem cells. And as I was saying, that it's the needling effect and getting more biology in blood and stem cells that's important. And ActiFit, if you look at ActiFit, the meniscus at the original meniscus has been basically NICE said you can't use it. But they're just bringing out ActiFit 2, which has got the scaffold plus a lot of the cells that transform in growth factor beta 3 that you were showing, and all sorts of other things that they've added onto it. So I think it will be a big thing, and the holy grail will be whether when we see a meniscal tear, can we just inject the knee with something and the meniscus repairs? So it is definitely a space to watch.
Can I just say, Amr, sorry, you know, lots of grey hairs to testify for this, but you know, Professor Bentley at Royal National,
yes,
was doing a lot of cartilage regeneration,
yes,
and went around the world. But the slides he would show would look no different from expensive scar cartilage.
yes.
You know? And that's fallen by the wayside. So you'd have to harvest the cells, sell them off, send them off to some lab, and then put them back. But I mean, so that's one thing. We've been down this road before. We've got to be looking, because I'm just looking at the lines. I'm not a scientist, but I was looking at the lines that Manora was showing. The IKDC scores showed that where it had failed, they actually did better in terms of symptoms and stuff.
Yeah.
The other thing,
nearly the same, not better, but nearly the same.
Nearly the same. Well, the line was slightly higher, but it might be my screen. But
Tariq, Amir, can I please? Both of you have done quite a lot of discussion. Can I add a little bit, please, if you don't mind? Now, you see, what Munawwar is saying makes quite a lot of sense. The reason being very simple. Whenever there is an injury, there is a biomechanical problem, and there is a problem with the biology. So what happens that now the stem cell, which is also PRP is considered also part of stem cell. I was looking into literature for the last 1 week because I'm giving a talk in BKS on ACL with PRP. And there is no doubt that all the literature which I've read, systematic view, level 1 study, and a lot of work has been done on ACL and PRP, a lot of work in the last 6 to 7 years. And good paper have come out with level 1 evidence. Interestingly, all of them have looked into 3 factors. Number 1, graft maturation. Number 2, osteointegration and tunnel widening. And last thing was clinical outcome. The only thing in every study which I read, and the whole conclusion was that the best function, what stem cell or PRP does to the graft is improvement in homogeneous graft maturation. There was no difference in tunnel widening. There was no improvement in function. So there is no doubt that in long-term clinical function, I don't know how much it will give benefit. But in a short term, decrease in edema, early maturation of the graft, there is a very strong evidence to prove that also on the histological examination. So I do back that up, that you can use stem cell or platelets unless your aim is to give early improvement in function in the form of graft. We don't know the long-term results, but there is definitely a huge amount of surge toward utilization of orthobiologics in knee. Function-wise, that's the main challenge now. That do they do better in function? None of the study actually used function as a primary aim. They all used MRI, histological examination, and overall graft integration. So let's see in future when the study will come, then they will see.
Sorry, Omar, why do you think that they haven't used function? Do you think it's on purpose, or do you think it's just the way it is?
I don't know the answer. But I'll tell you about myself, Amir. I don't know it's right or wrong, but I use on most of my patients after ACL reconstruction PRP in their graft. And I am doing prospective study, done 60.
We wait for your papers. This is about the meniscus.
I'm just giving you obviously an overall feel about orthobiologics.
Comment also, guys. Yeah. So the new kid on the block is stem cells and PRPs, but the newest kid on the block is modified. So we have been picked as a center by a company in San Marino which is called TissueMe or TissueU. And we are going to be trialing all my tennis elbows and golfer elbows patients with nothing but monocyte injections. And apparently the morphology doesn't change, the gross anatomy doesn't change, but the symptoms get better. And this is a study looking at functional outcomes. So that answers your question.
Yes, but whenever we talk about the meniscus here,
yeah.
which is
so in the meniscus, in the meniscus, most of the studies most of the meniscus in the studies that were done, they looked at function that I presented in, but the function was saying whether you did anything to them or not, because these were mechanical symptoms that got better. So even the patients that had nothing as control, they also showed the same results long term. So whether the biology is helping or not, we don't know, but there is evidence to support that it's not doing worse. Okay.
And the most other interesting part is it doesn't do any harm.
I think that is very expensive assumption to make. That is not doing harm, so we should do it.
Like, I meant to say that none of the study, I'm talking about obviously not the mesenchymal only stem cell, I'm also adding that into a PRP, that a platelet also doesn't cause any harm in any of the study which I looked at to the patient negatively. So I'm sure that there is a role of mesenchymal stem cells in human. And I think maybe with time, in another few years, we will have much more stronger evidence to support that.
So Sufyan is scratching his face, not listening to any of this, isn't it?
Masood Umar was going to say something.
Yeah.
I was saying injecting without evidence in our part of the world is a lot of cost to the patient. So if there is no proven benefit, injecting even PRP is 30,000 rupees. Stem cell, though jab aayega, though I think it will be much more expensive. So what we are talking here is our studies in just the formative stages. So living here in Pakistan and practicing only on the basis of 2-3 studies would be very difficult.
I think the most important thing.
Sorry, one thing. Just there's a study Zaman et al. Did, which was published in Arthroscopy in '96 or '97. I had to dig it up. But we looked at the asymptomatic knee at the patients presenting, and this was in Leicester. And 20 out of 21 had exactly the same tear in the asymptomatic knee. The only one that didn't had one in the lateral meniscus as opposed to the medial meniscus. So perhaps we should be actually getting them at the asymptomatic stage when they're much earlier. But if we're doing MRI-based studies, beware that you can have tears without pain as well. So a lot of...
And that's the basis of the funding decisions that are made. And this is when Masood Umar said who you treat non-operatively, and say those who have a full range of motion. So Tariq, you bring an extremely important point through, is that an MRI is quite sensitive. And maybe you could see tears earlier than they'll be clinically relevant. And the lateral meniscus is more important. Now, this is always I think about what would you do? And this is a question to Masood Umar Saab as well. If you've done an MRI for an ACL injury, which is shown, as they often do, a lateral meniscal injury, which is not broken into the surface, do you go and do something to that meniscus, like put a horizontal suture in, and this is for Umar Butt as well, or do you just leave it and think it will heal? What would you do? Umar Butt and Masood Umar Saab.
Masood, bhai, please, do you want me to start? Okay, simple. I just finished running, so I'm just a bit breathless. Okay, now Amir, if there is a lateral meniscal tear and or during ACL reconstruction, it's a stable tear, I would leave it.
But you can't see it in arthroscopy, but you know there's a tear on your MRI. What would you do?
So if I can't see it on arthroscopy and on examination with the hook and probe, it's not coming in the joint. When I'm manipulating the knee, it is stable in position, I'll leave it alone.
Masood Saab?
I'll leave it alone.
If
I can't see it, to
So can I conclude this and make a statement, and then we can call it a day, because we all have things to do, and it's Sunday morning. It's nearly 11 o'clock for me anyway. So I thank all of you guys, but we must understand that Pakistan is a place where it's all about money, more so than most places in our side. However, that does not mean we close our eyes to what the rest of the world is doing. We have to take the knowledge and information. We have to use it if it suits us, if it goes our way. If it doesn't go our way, then we don't have to use it. But we cannot.
But that's just there. It's not accepted in our world either. It's not. I cannot, at this moment in time, in my practice, in my private practice, I cannot go and just put autobiologics in. It has to be.
I never said that. I never said that. All I said was there is evidence out there. We just have to. My last slide was watch this space. I didn't tell you to guys and go and inject it for everybody. I'm just giving you the evidence that's around the world and what's developing.
But Amir, you are saying that you're not allowed in your private practice. I have seen many of my colleagues in London, Adrian Wilson and other guys, they are using autobiologics.
No, you've got to be very, very careful. What they have done is they have taken their practice out of a hospital. So there's Spire Company, there's lots of hospitals like the Nuffield that have governance systems. So what they've done is they've hired a separate clinic, which they run, and they don't have any external governance. So they can do what they want in their clinic because they operate under their own rules. Their clinic is very similar to a clinic that would be in the Middle East or be in a clinic in Pakistan. So Adrian Wilson, he's from Hampshire. I know him very well, and I do respect him from his knowledge point of view. But the London Regenerative Clinic was asked to leave the hospital they were operating in. So they've set up their own system. So be very careful about what you see or what people say. And it may be in 2 years' time, we are all injecting PRP and autobiologics. Yeah. But at the moment, it's centers that will give us papers like you, Umar, you'll be producing papers, Munawwar's producing papers, and inshallah we'll be producing papers.
What Munawwar was saying, I'll just add last slide. Munawwar, you are 100% right, and Masood Umar Bhai is 100% right. I would never do any practice unless I have a backup of evidence. Now, the study which I'm doing on peroneus longus versus hamstrings is ethically approved by United Medical and Dental. Okay. The second study has also been approved by United Medical and Dental, which we are doing on PRP. So unless I don't have strong evidence, I would not do anything without putting it through the trial.
What Ahmed was saying, sorry.
Masood Umar Saab had his hand up.
Yeah, okay.
Okay, my question was different. Are we out of biologics? How frequently do you see sympathetic dystrophy after a arthroscopic meniscectomy?
I have seen probably about 3 in my whole career, and they have been miserable. They have a stiff leg, they can't move it, they can't do anything. It's been horrendous. And
were they younger or older individuals?
Sorry?
Were they younger or older individuals?
So they were probably in their mid to late 30s. And one of them just was on a boat, and the boat rocked. They got a meniscal tear. They had a meniscectomy, and then they got the most florid CRPS, and they came to me with a stiff knee, and they've gone through all of the pain team, and they're even thinking about amputation. So it's a devastating complication, but you can't predict it. So all I can say is if someone, and the other more common, more happier state that you can do something about is neuromas. So if someone is complaining of ongoing pain and they've had an arthroscopy before, just tap around, and then suddenly you find they've got a neuroma. You inject it with lignocaine and steroid in your clinic, see them yourself 10 minutes later, the pain is gone, you may need to repeat it, and you may stop them having a knee replacement. They tend to be in their 40s and 50s, they have the ongoing knee pain, they then get a knee replacement if you don't pick up the neuroma. So that's another important thing. And especially if they had a meniscal repair and they've got nerve symptoms, just think, have you got a neuroma? And I think Tariq Daman raises interesting points about the outcomes we have now, but these will change over time. I think, Munawwar, you've given fantastic insights into the future, and we await the results of trials over the next couple of years. Umar Butt's doing fantastic work with the research, and we await his results also. But I think the most important thing is that we're having this conversation that we need to think about saving the meniscus, not cutting it out. And I think if we have that message, then we will do good.
Okay, one final comment. You know, I work also in the private sector. Like you said, the governance has not allowed me to do any of these biologics except PRP in tennis and golfers' elbows. It goes through a very strict, rigorous check. Not everybody's allowed to do everything. So you're absolutely right. Wilson is doing it in a free air environment, as you would call it. There is no control, no governance. So we need to quote evidence with a bit of pinch of salt, because he's not published anything, but he has a lot of claims. I do admire the man's brains, but watch this space. I say, you know, we need to preserve the meniscus at all costs. Okay. Before we finish, can I just have a show of hands or a view of this? The next topic, should we do a combination of hip, elbow, and ankle arthroscopy together, or so, and then we can move on from there onwards, or another topic that anybody wants to discuss?
I think we should alternate between shoulder and knee. I think next one should be shoulder.
I haven't got a clue about ankle and hip, Munawar. I haven't got a clue.
Yeah, but I mean, we need to complete the system.
No, I agree. Munawar, whatever you feel, that if it's hip, ankle, that's fine. So if all of us are happy, then I'm happy.
So Zaid Askar Saab has said that we need to do something on ankles because he wants to do ankles and he wants to know what the world is thinking about it. Right, so if we are going to do ankles, we might then fit in elbows and we can put hip into it in a talk like this. We'll have limited people. But
I think ankle is good.
Why don't you stick with ankle and hip together and bump elbow with wrist and shoulders?
Yeah, that's a good idea. Okay, so we'll have. Thank you very much for everything.
Thank you very much. Lovely.
We started with 3 people in the last meeting. We've now had 18 this time, so we are progressing.
Mashallah, very good.
Yeah, and John has been very quiet, so I'm upset, because if you've not said anything at all today, are you still waiting to start surgery? So should we let you go? Should we call it a day? Thank you very much, everybody.
Thank you very much. Take care. Bye-bye.
Thank you.
Bye-bye.